Go with let's go with transparency. My job, because to find out what he does, I have to introduce myself. What do you do, John?
There you go. You had such a rapport.
No, he's a lobbyist. Yeah, no, we sort of you would be really I might have a consultancy. Smaller companies that can afford to oh my God. Unfortunately, I couldn't play golf. This day and age, it takes 18 months to get there. So there's a lot of other things. September, they're still not here. Likewise. I read that like How busy are you? Yes. I saw Aaron. No, we met.
talking about yeah, I guess once a month. Like never. Good. This is my boss. Okay.
Yes, exactly. Yeah, you
This should be
Have you been listening?
I do, yes. Yeah, have we met before? Okay.
We've seen each other, or at least I.
Okay. Oh, okay.
So big of a lot. My experience on the board, big of a help.
Oh, okay.
So I deal with. I always mispronounce her name.
Bianca?
Yeah. What's her last name?
Amy Bianca?
No, there's another one. Okay.
Martha Clausen?
Yes.
Okay,
Yeah.
she's a healthcare lawyer.
Yeah. So that's who I always deal with. Yeah.
Oh, okay.
Yeah.
Okay,
So
great.
so you work with her?
Yeah, so Martha is the policy analyst.
Okay.
For Mass Health and Elderly Care Accounts.
Okay.
As well as health policy commission and GM.
Okay. You have a card?
And she doesn't have it. I'm so sorry.
If you could just tell me the note, I'd love to.
Yeah, definitely. Usually anything that
You're in there? Yes. Yeah. Yeah. So you have Mass Health as well as.
That's our office is now.
Okay.
So the capital process.
And we have another analyst, Amy Tinto, who does the mental health account, so you might also
Yeah.
Well, wonderful to meet you all.
Absolutely. Yeah. Thank you.
Oh, yeah. Oh my
To
gosh.
figure out somebody what's going on in the world of Jessica Simpson. Yeah.
Yeah. Okay. Okay. And then you must also know work with okay. Yeah.
Now, are you here?
Yeah. Only for about a month. Yeah.
Good luck with the major. Screw the oh boy. A lot of I'm trying to be the better. I have my success rate was 100%.
You try.
I gave it I saw him actually on Friday. His beer was probably 2 inches long. Completely red. It's just quite a
Yeah. Okay, that's fine.
Oh, yeah. Wait, where it says reserved?
Well, good afternoon. Welcome to the delayed, interesting meeting on the benchmark for the coming year and public testimony that we're seeking guidance on how we should proceed. Before we move further, I'd like to introduce Representative Roy, who will say a few words.
Thank you very much, Dr. Altman, Executive Director Sykes, and the HPC commissioners, staff. I'm Jeffrey Roy, the Vice Chair of the Committee on Healthcare Finance, and let me take this opportunity to introduce the members of the House that are here. We have John Barrett from North Adams, Daniel Cullinane from Boston, Daniel Donahue from Worcester, Carolyn Dyke from Holliston, Carmine Gentile from Sudbury, Randy Hunt from Sandwich, Lenny Mira from West Newbury, Matthew Murature from Plymouth, Stephen Altrino from Malden, and John Velas from Westwood. As the folks, everyone in the room here knows, it's been a difficult time for myself and my colleagues. On February 22nd, we lost our dear friend and chairman, Representative Peter Kokot. This happens to be the first meeting of our committee since his passing. I just wanted to say a few words. For those of us who knew him, Peter was an impressive man, both in stature and in character. He was the epitome of a gentle giant. First and foremost, he was a devoted husband and father. Peter was a family man, a sportsman, and a statesman, probably in that order. He cared deeply for the people of his district and worked tirelessly for them on Beacon Hill. First, he started as an aide, and then for the past 17 years as a state representative. He was named the House Chairman of the Joint Committee on Healthcare Financing in July 2017, and Peter immediately impressed everyone with his intellect, his insights, and his willingness to listen. Peter Kokot was a capable, compassionate, and impressive public servant, as I've come across, and his passing is a great loss. Our lives are a little dimmer with the passing of Peter, but the loss is nothing compared to the shining light he created in life, a brightness that shines on beyond his passing, and a light that will continue to guide us all as we strive to live up to his example. His work, our work, continues. But before we proceed today, I would ask that we all please observe a moment of silence to honor the life of Peter Kokot. Thank you so much.
Thank you. Let me go off script for a minute because I don't get an opportunity to address so many members, important members of our legislature. And thank you for what you and your colleagues did in passing Section 224. I've had the privilege of working at the federal level, and I'm particularly privileged to work for the state of Massachusetts. I get, and some of my colleagues get, the opportunity to go around the country. And the legislation you passed in 2012 and the various aspects of 224 are becoming the centerpiece of more discussions around the country than I can count. I've taught in California, in Delaware. David has been all over the country with many of you. So thank you for what you did. Now, in that connection, central to that Section 224 is the establishment of an annual benchmark. And I think everyone knows this, but let me just be very clear that this benchmark, while we don't have tight regulatory and force everyone to live exactly under that number, has become kind of a bulwark that everyone looks to in terms of how things are happening, where costs are going up, are they exceeding the benchmark? If they are, why? What would you do about it? So we in the Health Policy Commission, along with our sister brother agency, CHIA, are responsible for pulling together the information that not only sets the benchmark number, but also monitors it through the year. So today, as part of the law which you established, we are holding public hearings to get a sense from the various constituent groups that make up our healthcare delivery and financing system, what they look to. Now, as the law says, originally the benchmark was set at 3.6%, which is equivalent to what the estimate of our long-term growth rate for the Commonwealth. But after a couple of years, the plan was that this benchmark would go down to 3.1 unless we, the Health Policy Commission, felt that that was inappropriate, and then our other option was to go back to 3.6. If we did that, then it would go back to you in the legislature to decide whether that's the right number. But again, before we make that decision, we really are very anxiously looking to the people who will be testifying today. And then in April 25th, having listened to the testimony, looked at our own internal information, which we will hear some of it today, we will make the final decision. So with that as a background, we are going to begin the testimony. I just want to make sure that if there's anything else that you'd like to say. Good.
Just a brief opening remarks. Talking to begin with, there's great uncertainty today in healthcare, both locally and nationally. But here in Massachusetts, our efforts to address cost, quality, and access to healthcare continue in spite of the noise and confusion coming out of Washington. As Speaker DeLeo reminded us last week, we have long recognized the nexus between healthcare and economic well-being. And we approach healthcare both as a human right and also as a vehicle for change. For more than a decade, Massachusetts has been a leader in healthcare system transformation as we have expanded insurance access by promoting shared responsibility among individuals, employers, and government. We've adopted market-based insurance policies in pursuit of cost containment targeted towards commercial coverage with a focus on small business and self-insured individuals. And we've initiated comprehensive system-wide reforms to address deficiencies and fragmentation in healthcare by focusing on improvements in payment, delivery, insurance, quality, health information technology, and transparency. As House Vice Chair of the Joint Committee on Healthcare Financing, I am looking forward to working with all of my colleagues and with all of you to advance an agenda that sustains our commitment to the promise of Massachusetts healthcare reforms. Which brings us to today's proceedings. In 2012, as Dr. Altman outlined, we in the legislature committed ourselves to working towards lower healthcare costs by setting the healthcare benchmark target. For the first 5 years, many of our health policies have been set with a 3.6% growth target in mind. And we should be proud that working together, we have contributed to changes that have allowed our state to meet its benchmark target. As noted by the Health Policy Commission, the average annual rate of growth in total healthcare expenditures was 3.55% between 2012 and 2016. And yes, in certain years we exceeded the benchmark, but as our health reforms envisioned, we are looking at trend, not on-year snapshots. But it's worth noting that total healthcare expenditures per capita increased only 2.8% in 2016. Our healthcare spending is trending in the right direction, growing at a slower rate than any other state, to the point where we can finally say that we are not the most expensive state for healthcare in the nation. This is good news, and it's tempered by the challenges that remain, however. There is much more work to do, and deciding where to set the benchmark for 2019 is just one piece of the puzzle. As policymakers, we are looking forward to hearing from the panel and the experts today. To sustain our healthcare reforms, we need to maintain consistent communication with each other and work together. We must remain committed to pursuing value-based care and continually push the system toward efficiency and effectiveness. Earlier this month, Speaker DeLeo outlined how the House will lay the foundation of the evolution of healthcare reform in Massachusetts. Later this spring, we will finish the job that our chairman, Peter Kokott, had started by taking up legislation that will bear his name and that will enhance access to high-quality, affordable healthcare. The House approach will focus on maximizing the structures we put in place in our 2012 healthcare law. The Peter Kokott bill will emphasize policies to improve transparency, empower small businesses and individuals navigating the health insurance market, and integrate public programs like MassHealth more fully into the cost trends and oversight system. The policies we adopted in the past are not set in stone, but they are showing results. So while we continue to move forward on the path we set in 2006 and in 2012, let us remain committed to continual improvement in our approach to a more sustainable and equitable healthcare system. And let us always keep in mind that success will not be measured simply by our ability to keep total healthcare expenditures down, or even in our ability to lower premiums. No, our success will be measured by how we help all of our neighbors in Massachusetts, especially the people on the fringes of the system, get access to the care that they need. And we will be measured by how well we treat them. We are here today not just to make insurance more affordable, but to make our healthcare system accessible and effective to all. So thank you, Dr. Altman.
If you'll forgive me, Vice Chair, we need to officially do one or two things within, and then we'll get to the public testimony. First, I want to introduce our newest addition to our commission, Chris Kreider. Chris, welcome. This is your first meeting officially, and you couldn't be coming at a more appropriate time. So thank you. Second, I want to get an approval for the minutes of January 31st. Are there any additions or corrections? If not, is there a motion to approve? All right, all in favor? Very good. One final important activity. I ask approval from my fellow commissioners to reappoint Wendy Everett as the vice chair of the commission. All in favor? Any opposition here? Good. All right. Now I'm going to turn the program over to our executive director, David Self, who will lead us through some fact-finding about what's been going on. David.
Good afternoon, Vice Chair Roy, and through you to the members here today. This is a very important meeting of the Health Policy Commission. Before we move to the hearing on the benchmark, there's just one final piece of business from the Health Policy Commission standpoint, which is a vote to authorize the issuance of the 2017 Cost Trends Report. This has been a report that tracks trends in our healthcare delivery system. It is our annual report with policy recommendations. Commissioners, we have discussed this at previous board meetings, but the vote that I would ask you to consider today is to allow for the public issuance of this report.
Okay, so we need an official motion to approve and to publish the report. All right, second? All in favor? Aye. Any opposition? I've read through it. I'm sure all of you have read through it, David. A masterful job on the part of you and your staff. I know we went through much of the substance in previous meetings, and I'm sure it's going to be bedside reading for everyone in the Commonwealth.
Thank you, Commissioners. And with that, I think we will proceed to the full hearing today. And for members of the Joint Committee, you have in your packets a presentation with this slide as the cover. This will be the presentation that we'll be walking through today. Our plan for this particular hearing is that first, myself and our Director of Research will provide a background on the benchmark modification process, as well as present some recent trends in healthcare spending to help inform the Commission and the Committee's consideration of the matter at hand, which is the modification of the benchmark. Director Auerbach will also present to this board and to the Joint Committee a series of savings opportunities that we have modeled, where if the Commonwealth were to make progress on some key priority areas, that we would be able to both save money in terms of our healthcare spending, but also improve care and improve quality. And this modeling will give the committee and the commission a sense of the scope and scale of where some of those opportunities to really create improvement in our healthcare system and what that means in terms of dollars potentially saved. Before I launch into the presentation, though, I do want to provide an opportunity for Michael Cannella, who is lead staffer for Senator Jim Welch, who unfortunately cannot be here today, but I know the senator had some remarks and some points of view that he wanted to be able to share with the commission and the committee right up front. So, David.
Good afternoon. My name is Michael Cannella. I'm Chairman Welch's Legislative Director and Counsel. Unfortunately, due to a last-minute mandatory Senate caucus, the Senator and, as you can see, his other colleagues are unable to attend today's proceedings. But he requested that I deliver his prepared remarks on his behalf, and I appreciate the HPC's understanding and allowing me to fulfill that request here today. So I want to begin by thanking Vice Chairman Roy for his kind words about Chairman Kokot, leading us in that moment of silence. Many in government consider Peter Kokot to be a dear friend, in addition to being a tireless colleague. His loss leaves a hole not just in the legislature, but in our hearts as well. In the face of this loss, our committee's work must continue. I'm working collaboratively with Vice Chairman Roy over the next few months. I have confidence that we will be able to honor Peter's legacy. I want to thank those testifying here today, members of the public that have joined us here in person, and those who are watching online. Your continued engagement is what makes this and other healthcare policies in the Commonwealth work as well, if not better, than the policymakers could have hoped. Lastly, I'd like to thank Chairman Altman, Executive Director Seltz, and all the members of the Board of the Health Policy Commission for hosting us again this year on this important hearing on whether changes should be made to the healthcare cost growth benchmark. This hearing furthers the data-driven conversation on healthcare and healthcare cost containment that was central to the vision and purpose of Chapter 224, and is an important opportunity to learn about the trends that are emerging in our healthcare marketplace and how those developments will impact our performance against the chosen benchmark for 2019 and beyond. The hearing takes on added importance this year while the legislature works to advance additional healthcare policy reforms. Thank you for this opportunity. Thank you, Michael.
So moving into the staff presentation, first just wanted to provide a background on this process and on the benchmark. The healthcare cost growth benchmark is the central organizing principle of Chapter 224, recognizing that the high and rising cost of healthcare was crowding out the ability for government, for businesses, and for families to make investments. The state set a target for controlling the growth in healthcare costs. And I want to emphasize again that this is still a rate of growth. And because of the importance of our healthcare sector and the services that it delivers on behalf of the residents and citizens of the Commonwealth. However, throughout the 2000s, Massachusetts had healthcare costs that far exceeded national growth rates, culminating in 2009 when Massachusetts was the highest per capita healthcare cost state of any state in the country. As Vice Chair Roy mentioned in his opening remarks, we are no longer #1 due to some of the progress we've made in the last few years. We're #2, and having been surpassed by Alaska. But for this benchmark really is kind of the principle around which all of the activities of Chapter 224 reside. And so here you can see that for 2013 to 2017, that benchmark was set at the long-term rate of the economic growth rate at 3.6%. Last year, we held for the first time a public hearing, and the law establishes that the growth rate shall be equal to the economic growth rate minus 0.5% or 3.1%, unless the HPC board decides to affirmatively change that benchmark to some number between 3.1 and 3.6% growth. And that really is the question that we are here to consider today. Importantly, the benchmark includes all spending in the healthcare system, including Medicaid, Medicare, and commercial health insurance spending. It also includes out-of-pocket costs in the form of co-payments and deductibles. And the principle here was to help avoid cost shifting among different parts of our healthcare system and to really take a holistic view of spending and utilization within our Commonwealth. This next slide just talks briefly about the determination of the long-term economic growth rate. This is something that is established annually by the legislature and the governor through the consensus revenue process. So each year this number is revisited, and there's a new target established in terms of what the long-term growth rate of the state's economy will be. The consensus revenue process and the legislature and the governor agreed again this year that the long-term growth rate would be 3.6%. So that becomes an important number as we consider where to set the benchmark moving forward. As has been mentioned, this is just the second year that we've had this opportunity to modify the benchmark. For the first 5 years, it was set in law to be equal to the economic growth rate, or 3.6%. And as you can see on this kind of grayed out box, starting in 2017, it is 3.6 minus 0.5 or 3.1. And the board will have to determine whether it's reasonably warranted to modify this benchmark. In deciding whether to modify the benchmark, the HPC holds a public hearing, which we're here today to do. We consider data and information as well as testimony from the public. If the board decides to modify the benchmark to any number besides 3.1%, there is an additional notification process that goes to the Joint Committee, and the Joint Committee has a responsibility to hold an additional hearing and make recommendations. If the board decides to maintain the benchmark at 3.1, we will provide notice to the Joint Committee, but no further action by the Joint Committee is envisioned in the law. This slide I won't walk through, but really is just a reflection of some of the different factors that the board considers when deciding whether or not to modify the benchmark. And we're going to be presenting some information today on some of these important factors. What has been our health system performance to date? What is the impact of demographic changes on our performance? And where have we seen and can identify opportunities to drive savings in our healthcare system that would allow us to think that we can meet this aggressive benchmark without sacrificing the high quality and access to care that is the hallmark of the Massachusetts healthcare system. So with that, we're first going to focus on some data and trends around what has been our health system performance to date. And so I'm going to turn it over to our Director of Research and Cost Trends, Dr. David Auerbach, to walk through a few slides that will provide some background information on the Massachusetts performance so far.
Okay, great. So let's start with our performance against the benchmark in the last 4 years, which we've recorded that. As mentioned earlier, in aggregate over the full set of these 4 years, we've been growing at 3.55%, so just under that benchmark. And the table below shows that that is below the rate of spending growth across the rest of the country. But it is still higher than the growth in wages and salaries in Massachusetts. It's higher than the rate of inflation. This is part of the motivation for hoping to do better, so that people aren't continually spending more and more of their earnings on healthcare.
And I would note to the commission and to the joint committee, please, if you have questions, just let us know, and we're happy to stop along the way and answer questions.
This slide shows a longer time trend of spending growth in Massachusetts compared to the rest of the country. And you can see again reflected here that we are the orange, and we've been below that national rate in the blue for about the last 7 years in a row. And that lower rate, that's a composite of spending in a number of categories of care. So where have we grown more quickly and where have we grown more slowly? The slide shows for the last few years, you can see prescription drugs, pharmacy in the middle there as a higher category of growth. Hospital outpatient care on the left grew pretty quickly in 2015-16. So this is showing some of the areas that we're going to focus on in our cost savings part that I'll get to later. You can also look at trends just in the commercial market alone, where a lot of our interventions are focused. Again, we have grown more slowly than the rest of the country for the last 4 years. Although that growth, we're again in the orange, has been inching up over the last few years. This slide is showing premiums in Massachusetts compared to the rest of the country again. And you can see reflected in that lower growth rate that we've had. In 2012, our family premiums were about 11% higher than in the rest of the country on average. And for single coverage, about 14% higher. By 2016, due to that slower commercial growth, those gaps have come down. It's about 7% for family coverage and about 9% for single coverage. We are still higher, but the gap has shrunk. Noting at the bottom, these are really high numbers. The average family premium is about $19,000 in 2016. Families paying over $21,000 when you consider co-pays, deductibles, and that's just on average. For 10% of families in Massachusetts, total payment for health insurance is over $29,000 per year, and that was 2016. Acknowledging that that payment is partly made by families and partly by their employers, which all is part of their same total compensation package. This slide is showing that, in fact, for lower wage firms, which are the Q1 on the left, a quarter of firms in the state with the lowest average wages, those contributions that employees pay to their family premium is actually higher than in the higher wage firms. That's a significant contribution and a significant burden of healthcare. The next few slides are showing some opportunities for improvement, highlighting some areas where our trends are concerning and in some cases worse than what's happening in the rest of the country. Here we're looking at readmission rates in Massachusetts. We have a comparison with the United States, and at least when we look at Medicare patients, and we were trending downward in 2011 to 13, but since then we've been trending upward. We're having higher readmission rates than the rest of the country and diverging from national trends. And that will be a focus of one of our savings estimates. Here showing another trend of concern, we're looking at community appropriate care at low acuity hospitalizations that can be handled at any hospital in the state. And we're looking at what % of those are treated in a community hospital versus a teaching hospital. And that share treated in the lower cost community hospitals has been declining each year since 2011. And finally, a slide showing our trend in the use of alternative payment models. The focus of the Health Policy Commission to move away from fee-for-service methods, which reward providers for volume instead of value. In the commercial market as a whole, about 42% of payments were under one of these global budgets or other sorts of payment models that are paying for value. That's a positive uptick since 2015, but as I'll show later, there's still progress to be made, and it's important to have that be a growing share of payments. Otherwise, providers are often in a case of part of my patients are paid fee-for-service, part of them are paid with these alternative methods, and I'll often use the analogy, I've got a foot in both canoes. If I avoid unnecessary care over here, I lose a lot of revenue, and I don't make it up for it over here on my other contracts. You kind of have to have both feet in the same canoe. Okay. One more trend that affects our ability to meet the cost growth benchmark is the aging of the population. This is happening in Massachusetts and everywhere. We presented this last year showing that, for example, the percent of Massachusetts residents over age 65 has been growing and will keep growing. And we see that in our upticks in Medicare enrollment year after year. This trend alone is expected to add about 0.5% to healthcare cost growth each year. Now I'll transition to a few national trends, just to give us a context of some of the things going on in the rest of the country, and these often do affect what happens in this state. For example, prescription drugs are a national market, and what happens in the country often is reflected here. On the left, we're showing total health spending growth. It's in the 4 to 5% range, 2015, 16, and 17, and that's divided into components of how much is due to price increases, how much is due to everything else, utilization of care, using higher intensity care, population aging, and you can see that they both contribute. And on the right, the price growth specifically has been high in the commercial hospital arena. It's been lower when you're thinking of Medicare and Medicaid. Those prices have not been growing. So price growth has been an important contributor, but relatively low in the last few years, except for the cases of prescription drugs and commercial hospital prices. But when you look at that in a wider context, and this is some historical data and some projections from the Center for Medicare and Medicaid Services, CMS. They're looking at national healthcare spending growth, divided again into prices and utilization, and you see that in 2014 to 16, the price component, that blue, is relatively small. It's been a low price growth era for the last few years. But it used to be higher, and they project that in the future, prices will be accounting for about half of total price growth, total spending growth. It'll be a bigger component than it has been. So here is the full CMS projection for healthcare spending, all the way up to 2026, which was recently released. You can see historical spending growth year over year, separated in component of care by hospital, professional, and prescription drugs. It's been around 2, 3, 4, 5% over the last few years, and CMS expects that to settle in at around 5% moving forward. And you can see slightly higher for prescription drugs. They're expecting some new drugs in the pipeline coming onto market and so on, and that growth will push up total healthcare spending growth. Aging of the population is also a factor in here. Okay, let's pause there and see if there are any questions on trends that I've shown before we move into some of the savings opportunities.
Are there any questions? Anybody? Sure, please.
In the cost estimates that you have included, have you been able to break out and determine how much of the cost increases could be attributed to substance use disorders or the opioid epidemic?
So we have not calculated what the impact in terms of spending over the last couple of years due to the opioid epidemic. We did release a report last year that examined the increase in emergency department visits and hospitalizations due to patients suffering from opioid use disorder, and expect to update that report again this year, but had not taken the step to calculate what that additional spending may be. And I guess I would note that that spending of patients arriving in the emergency department or in the hospital is in many cases is very appropriate spending. These are patients who are receiving emergency care, and in some cases that it's a reflection of our success in getting Narcan out into communities and reducing the mortality rate of the opioid use epidemic, that people are accessing health care. And so would want to think carefully about how to calculate that in a way that would not make it appear that this is somehow wasteful spending in the system, but absolutely is having a tremendous impact on our healthcare system.
Yes.
If you comment on trends in out-of-pockets.
Yeah, sure. CHIA reports that year after year, and I didn't include it here, but trends in out-of-pocket spending have been growing faster than premiums, reflecting probably more and more high deductible plans showing up in the market. So they're reflected in those total commercial spending trends that I had back here. It should be reflected in there, but it's true that if you compare just out of pocket, those are growing faster than the overall by maybe a percentage point or two. So that's the point.
David, I was wondering if you looked at the correlation between the U.S. inflation rate going back and healthcare costs and what we're expecting this year. I think you'll find if you go back to the 60s that healthcare costs is directly correlated to U.S. inflation, and it's a factor of 2 to 3 times the U.S. inflation rate, and it's been very consistent. So if you take last year as an example, we had an inflation rate of 1%. Then you look at the healthcare costs. So going forward, when we're breaking this down, we're looking at the benchmark. One of my questions is, if you take Medicare as an example, the population that we have of Medicare, the likelihood of Medicare falling below 5% is almost impossible, because part of that is federal in nature to begin with. And when you're looking at supplemental plans, we're the most expensive in the country. And that's based on utilization and things of that nature and age, right? So when you're taking all that into account, and when we're looking at the numbers and we're looking at solutions, are we taking into account the variation between, in general, between Medicare and commercial plans and mass health type plans? And what's the likelihood from your research on us being able to hit the numbers? What's important, I believe, is if the numbers aren't close enough to reality, they're going to be ignored.
That's a fair point. We do consider all those sectors. They all go into the benchmark calculation. And usually in our cost trends report, and we do it this year, we do separate out the growth by Medicare, mass health, and commercial. So you can see those numbers. I don't know if I have them. I think it probably does right here. And the Medicare growth has been helping us over the last few years. I'm pretty sure it's been in the kind of 1-2%, 1-3% range. And that's partly due to changes in the federal structure and federal payment rates. They've been trimming those hospital payment rate growth over the last few years. Yeah. 2 to 3% growth in Medicare, mass health in the 3% range. So I wouldn't say that it's a particular challenge beyond the same kind of cost control efforts that we'll be showing here today. Yeah, go ahead.
Dave, I'm confused about the Medicare numbers. Last year, Part B went up 10% in premiums. The year before, it went up 16% in premiums. Supplemental insurance at the high end is going up 3.8% a year, but that doesn't count age because it's based on age as well. When you add age into it, you're looking at a 7% plus increase a year. Out-of-pockets are around 3 to 5%. Is this based on utilization when you're looking at total spend in the state, or when we look at it from an individual standpoint, what an individual resident in Massachusetts who happens to be retired, how are their numbers looking versus the cumulative? It's interesting, the point that you make, if it's only going up 2% or 3% on a cumulative basis, that's the overall spend, but not necessarily related to the individual. Is that correct?
Sure, that's the total spend, and that'll reflect out of pocket, but I don't think we have supplemental coverage reflected in the THCE numbers. So probably some of the things you're mentioning, we might be able to look at other sources and think about that.
Thanks.
I just want to add one comment to one of the points that Ron made starting off, which is that at least part of the price increase forecast that David was pointing out is in the actuaries' projections is coming from overall general inflation, which they assume will rise above the 1%. That's correct, and so they think that that's part of what will go up, and that will obviously affect healthcare input costs and thus the need for healthcare prices. And that goes at your issue about what is an appropriate. Are we even in the ballpark for what is a reasonable estimate?
I do feel obligated to say one thing, Ron, because I think the numbers are very interesting. But there's no kind of you implied that somehow there's a force that has that happen and there's nothing we can do about it. And that just flies in the face of everything we're all about. That is not something that that the healthcare delivery system, that the financing system, that's why we're all about this, to try to mitigate the relationship between them and bring them down. If in fact it was a force that we couldn't stop, we wouldn't need to be here.
No, I don't think that if that's what you read into what I was saying, that's inaccurate. I think there is a lot that we can do.
Okay.
I think we also need to understand there's some realities. Some of these numbers are federal in nature, like when you're looking at prescription drug costs. There are limited things that we can do there. But one of the most important things that I think we can do, Stuart, is on the transparency issue. If you have over 20% of the population that's in a high deductible plan, and those of us who happen to be in bronze and silver plans, we're still paying thousands of dollars in deductibles. Knowing what those costs are and truly having transparency, I believe in a marketplace, when you're looking at the majority of people that are going to be out of pocket, we will, as consumers, put in the time and effort to look at what we're spending. And that becomes a critical issue in terms of managing costs. So I do believe there is something we can do about it. But at the same time, I think it's important that we look at, is the number a reasonable number, so that providers are looking at that and is striving to achieve the number. And I think we need to look at both.
I have a clarification question on this, the chart on the national trends. And in 2014 to 2016, the healthcare price piece was a much smaller. On my in my packet, it's slide 18. Yeah, there we go. I was interested, after looking at the demographic information, it surprised me that the utilization piece, you would think with the aging demographics, the utilization would be consuming a larger portion of that 17 to 26 bar, and it's not, it's a bigger price component. So I'm just wondering what the dynamic behind that is, if you can clarify.
Sure. The aging should be pretty much the same in both of those. And the difference is, I mean, one thing is that the 2014 to 16 is observed. That's historical. The other bar is a projection. So utilization increases were significant in that 14 to 16. You had a lot of insurance coverage expansion, for example. People were just using more total care. That's not expected to be in the 17 to 26 bar. So that's probably most of that orange wedge that you're seeing there that's not repeated in the next part. So the aging is in both. It is.
Yes, sir.
Thank you very much. I have a quick question. You may not have numbers on this or access. We look at all these numbers. We look at the expense of healthcare. We're fortunate to have some of the best hospitals and teaching hospitals, not only in the country, but in the world. But is our society healthier as a result? I know we're increasing access, and I come from a community that's middle to low income. We're making great strides in access to health. Is our population healthier? You know, it's a tough sell to some folks who will just look at charts and say, this is where we should be, this is how much we're spending.
That's an excellent question. I mean, we should think about everything we're talking about today as kind of within the medical care system, which is really a small piece of our overall healthcare picture. There's so much more on the outside, our lifestyles, social determinants of health, and those things obviously do interact. And the kinds of discussions and interventions in our purview are more in that healthcare circle that we should never forget about everything on the outside of that.
There certainly have been a recent national ranking that ranked Massachusetts the healthiest state in the country. When we compare the United States to other developing countries, we lag on a number of important health metrics, and some of that is related to the balance between spending in the healthcare delivery system versus spending on other supports and social services that other countries may invest more money in.
So we are ranked the healthiest country, the healthiest state in the United States. That's an average. It's an average, and when you actually peel that number back, you see wide disparities, particularly among certain populations where English is not the primary language, individuals from Hispanic and the like. So while we should hold on to that number one ranking, we shouldn't be running around the track except to stay healthy. But to really then understand what lies underneath that number. And as I think if you really want to look at how we do in outcomes, it would be to compare the United States against other countries that are similar to us, where our health outcomes are not nearly as good as some other countries.
Okay, so moving on to the next part of the presentation. This was an exercise that we did last year to try and provide some modeling around where are some opportunities to create savings in our healthcare system. So as we just noted, the national trend moving forward is projected to be around 5% growth a year. And we are considering setting a healthcare cost growth benchmark for this Commonwealth at 3.1%. So achieving that benchmark will require us to continue to diverge from the country in terms of our growth rates, consistent with what we've been able to achieve the last couple of years, but even more so moving forward. And so what we've done in the next couple of slides is just provide a limited set of where some of those opportunities could be, where if we were able to make some significant progress, we could generate some significant savings that would allow us to comfortably meet the 3.1% benchmark while not sacrificing, again, quality or access to care. So I would note here, these are not an exhaustive list of where there are opportunities for savings. These are really derived directly from our cost trends reports and where we have good available data. There are many places where there are lots of different ideas to generate savings, and they may not have the best data to model this. So these are really illustrative what-if scenarios, and what we've done this year, different than last year, is we're showing you savings over a 5-year period of time. So these are our 5-year estimates. We have also, while we're not showing it here in this presentation, been able to break this down by commercial and Medicare, and in some cases, Medicaid spending opportunities. So we have identified 7 opportunities that we'll walk through relatively quickly, where we have modeled what would progress look like and how much opportunity is in some of these areas. You can see the 7 here, but I'm going to turn it back over to David to walk through each of these in turn.
And I will say there's going to be more detail on these available in just a few days on the website with some of the assumptions and background. And we should have Rosie Kerber in the room who led this effort on my team if there are questions that I can't handle today. Okay, so here we go. Topic number 1, hospital readmissions. As I showed earlier, we are in the lower half of states in success on this measure. And for example, in terms of the Medicare program, our readmissions rates were 10th highest in the country. 18.2% of people admitted to the hospital are readmitted back within 30 days compared to 16.8% in the rest of the country. We have talked about this in past cost trends report, and if we set a target, for example, that we can reduce that by 20% off of what we were in 2015, I'll show you what those savings would look like. This is showing the savings estimate with the orange is what spending would be if we achieved that target. And we're modeling that we would achieve that little by little each year to reach that 20% reduction. And the total savings would be just over $1 billion cumulative over the 5 years. Next topic is post-acute care, which we also have talked about in past cost trends reports. This is an expensive category of care when we're talking about discharges from the hospital to institutional care, such as a skilled nursing facility. In fact, among 36 states that submitted data, we were the highest. 20% of our hospital admissions were sent to one of these expensive post-acute sites of care. And in this target, we are envisioning reducing that 20% down to about 15%, which would put us about 14th best in the nation among these other states. If we achieved that reduction, we would save about $1.37 billion over the same 5-year period. Next topic is avoidable emergency department use, which we have talked about in the past. We can categorize emergency department visits in terms of some percentage of them were not an emergency in the first place. Some percent of them could have been treated in other settings, such as primary care office, such as an urgent care center, for example. In this estimate, we envision reducing about 2/3 of those that weren't emergencies, some of them disappearing entirely and some of them shifting to lower cost sites of care. And in addition, shifting 20% of the ones that could have been treated in another setting to primary care offices, to urgent care centers. This affects both commercial and the mass health. We have estimated the savings in those populations both. And the next two slides show how those savings break down into two separate categories. First, reducing those that were not emergencies by 2/3. You can see the savings, about $260 million. That is netting out a small increase in costs to primary care where some of those visits now would go. And the second category, shifting those that could have been treated in other settings, an additional savings of $91 million over the 5 years.
I would point out, particularly since you're focusing on mass health, that emergency rooms are available 24/7, and many primary care offices are still on a Monday through Friday, 9 to 5. And so if you are working on a 7 to 3 shift, it doesn't give you, you don't have a lot of time to take off. It doesn't give you a lot of opportunities to seek your care.
Absolutely. And we hope that those opportunities expand, but they are not always there. The next category is community appropriate discharges, which I referred to earlier. Hospitalizations that could take place in community hospitals, but are taking place in teaching hospitals. Here we imagine shifting about 1/4 of such hospitalizations over this 5-year period gradually. If we were able to do that, and this estimate is in the commercial and Medicare population, we would save $211 million over the 5-year period. This is a category that we discuss in our cost trends report, which should be available very soon. Hospital outpatient care, as I showed earlier, was one of the fastest growing categories of spending. And in this case, we looked at a number of common procedures such as MRIs, colonoscopies, typical E&M evaluation visits that sometimes take place in more expensive hospital settings, could just as well take place in freestanding centers and clinics and physician offices, often at half the price or less. So we envision here what if payers paid only that rate at the physician office or the freestanding clinic and not the hospital rate, which some payers in some parts of the country have started to implement. Or a flat rate, yes. You can imagine it that way. A site neutral rate is often used. Exactly. And if we did that for just this set of 19 conditions, just in the commercial market, savings would again be over $1 billion over the 5 years. Next category is prescription drug spending, highest growth driver over the last several years. In this case, we envision limiting the growth in prices. And just for a subset of drugs, just those that account for half of total commercial spending in a given year. So here, if we cap that level of growth at 1.6% per year, total savings would be $230 million over the 5-year period. Finally, expanding use of alternative payment methods. In this case, as I noted, alternative payment methods right now are used by about 42% of the commercial market. It's much higher among HMOs where it's easier to do. It's lower in the PPO plans, where it's a little bit more challenging to attribute spending to a specific physician. But payers are doing it, and this is where a lot of the growth opportunity is. We imagine that increasing the penetration into those products of up to 68% in the HMO market and up to 40% in the PPO market would have significant cost savings potential in enabling more and more provider groups to ride with both feet in that same canoe and reap the rewards of reducing care that isn't necessary. And this slide shows a little bit differently what achieving those target penetrations would look like. The blue line is the percent of HMO patients that are in an APM, and the dashed is showing what that growth would have to be to reach this target, and the PPO is shown below in the orange. So if we were able to achieve those increased rates of use of alternative payment methods, savings would be almost 500 million over the 5-year period. And we modeled here, I'll just note, that once providers reach a tipping point when most of their patients are paid in this fashion, we modeled an increasing amount of savings, which is consistent with what the literature shows. So you get an acceleration once you reach a certain threshold. Okay.
Can I ask you a couple questions?
Yes, please. And that was the last one. Here, I'll just show the summary table. This is combining all the savings. And we've broken out the commercial market below, and the total savings is 4.7 billion with these estimates over the 5 years. About half of those from the commercial market. Yes, please.
Spectacularly good work. Thank you, David. 2 questions. Maybe use the chili table if you want.
Yeah.
On the first 2 categories, the way you reduce readmissions or change care from post-acute is by putting other services elsewhere. You had a countervailing cost on the affordable EDs, but not there. Is that right? Should you assume that money has to be put into other methods to help people stay home, right?
That's a good point. These really, we attempt to, where there was an obvious place where the care would shift to, we did try to reflect that. In the post-acute care situation specifically, it's interesting. When we thought about this last year, we essentially shifted all of those skilled nursing facility discharges to a home health care. This year, we have noted that we are also the 2nd highest state in the country in use of home health care, and we are very low in the use of just discharges to home with monitoring, with a physician visit. So we felt like in that case, there would probably be a cascading shift of some SNFs to home health and some from home health to routine and monitoring. So we don't really see an offset in that situation. There could be, these are of course projections and estimates. Readmissions, we didn't consider the additional effort and cost of new, let's say, discharge planners involved in achieving that, which is significant and is a fair point.
And when so on the alternative payment, the way the APMs achieve cost reduction is through avoiding admissions, readmissions, and post-acute. So are we double counting there?
That's a hard one. There is the most overlap between the alternative payment methods and these. In some sense, we might be double counting, but in another sense, I think there would be synergistic effects that maybe we're even undercounting. So, on average, it's probably pretty fair.
And I just want to highlight again to the Secretary's point, achieving progress in any one of these categories may require changes in the delivery system, changes in the payment system, changes in policy that is not to present to this commission or to this board that one can snap a finger and achieve these targets. Any one of these would require coordinated collaborative action and potential policy changes across a whole host of different areas so that there would be access for patients who we know that the #1 reason that patients go to the emergency department for an avoidable ED is because they did not have access to care, or if it was after hours care, or they couldn't get an appointment on that particular day. So want to just emphasize again, achieving progress in these areas would require coordinated action across a number of different market participants, policymakers, and others.
So would you go back to the prescription spending slide? So since prescription drug spending has doubled in Mass Health for the past 4 years, the fastest growing part of the Mass Health program, and we've attempted to ensure access and manage the benefit, I'm sort of wondering, and I see the pipeline of accelerated drugs that are coming onto the market of the accelerated FDA process. Can you just tell me, I didn't see any so bringing it down 1.5% is a nice goal here, but how? Since I mean the next, so I can just give you the number, the next 15 drugs that are on the list for acceleration will cost Mass Health $80 million. Just so on top of a $2 billion pharmacy program already. I'm just sort of curious, what your thoughts are on this, because obviously pharmacy, a state's ability to particularly on drugs that have no competition, orphan drugs, which is actually what's quickly coming to market. What's the levers?
Yeah. So there are a number of states who have passed legislation specifically focused on prescription drugs. A few, including New York, California, and Maryland. Many of those are being challenged in terms of the legal authority for the states to, in some cases, have greater regulation on prescription drug prices. Where I think states have been most successful, which was not the focus of this modeling, but is actually in the Mass Health program and in the Medicaid program. And I would note in our cost trends report, we do recommend that policymakers consider enhanced authority for our state Medicaid program to negotiate around drug prices and rebates specifically, and that is something that the New York model has also adopted. So would recommend, I know this was commercial, but there are some proposals specifically in the Medicaid program that are worthy of consideration.
I think that's an important thing that legislators should look at. As a matter of fact, if we don't make changes when it comes to prescription drugs within 10 years, the cost of drugs will be around 27-28% of our total healthcare spend, which is unbelievable when you look at the growth rate in comparison to all the other segments. And it's not an easy issue to address, but if there's a way we can, as a state, negotiate with vendors in Medicaid and portions of Medicare, because we do run the drug program in Medicare. It's a state-run program that's a portion of Medicare that's run by the state. If there are things like that that we can do, it can have a significant impact on our costs. I think you're absolutely right, David.
Thank you. And thank you for this work. It looks like a lot of time and effort went into it. I think you hit upon what I'm going to ask for. When I Google cost variation for healthcare, Massachusetts is always at the top of the list to the point that knee replacement can cost $18,000 in one Massachusetts hospital and over $52,000 in another. Likewise, a hip replacement can be $18,000 in one hospital and $74,000 in another hospital. This is all within Massachusetts. It's huge cost variation. I think you hit upon it. With community appropriate discharges, is that what that refers to?
Yes, but the issue is even larger than what we modeled here. And this really speaks to the wide variation of prices for the same services, for the same type of patients that exist in our market. And and we've documented this for hip and knees, for maternity care, for a whole host of different procedures. So I think the opportunity around addressing that variation would be much greater than what we presented here, which was really just specifically focused on shifting some hospital care to community hospitals.
No, but is there any idea why this takes place? Why doesn't a patient simply choose the bed? Is it a case of the patient doesn't know what the cost of these procedures are, or they don't care because, quote unquote, someone else is paying for it? Any idea why there's such a variation between hospitals?
That's a great question. In fact, we did a study. We participated in a grant with some researchers at Tufts to ask really that very question. And we had some focus groups and patient surveys, and it's kind of all of the above. They partly don't know the differences. They partly just take what their physicians, maybe their PCP is recommending a hospital, or maybe they're affiliated somewhere, and they just sort of flow along. And even sometimes those physicians don't know the cost differences. And sometimes people have a perception that, well, the quality is better at some places, and if I'm not paying that much out of pocket, I want to go there. And their perceptions of quality often don't meet what the actual.
Well, yeah, that's what I'm finding. The outcomes seem to be the same at a community hospital and a teaching hospital. So the knee and hip replacements at Anna Jake's up near me is basically the same exact thing as one done at Mass General. The same kind of outcome. That's why I was just trying to get to the reason why patients would choose to go into Boston at a teaching hospital, a much more expensive setting, than say a community hospital.
In some cases, if a patient has a $2,000 deductible, they're meeting that deductible no matter where they go, and then a whole host of different reasons may impact that patient choice. I would note, we have looked at the underlying phenomenon of variation. That variation is highly correlated with the market power and leverage of certain organizations, and it is not correlated with the quality of care being delivered.
Thank you.
Other comments or questions?
I wanted to just ask the question of whether we actually need pharmacy benefits managers, or are they just a middleman that drives up the cost, drives up price? Do they add any value whatsoever? I give an example with CVS Caremark, who has a sizable share of the market. Their price lists that they sent out to their pharmacies in late October are such that independent pharmacists, any pharmacist, can't fill a prescription without taking a loss. And the loss they're taking is on the cost of acquisition and what they're getting reimbursed. It doesn't factor in their cost of having a human being process the prescription and deliver it. 165, I think, independent pharmacies went out of business in Ohio last year. We don't even have that many independent pharmacies in Massachusetts, so we lost some last year. So the question is, are they adding value, or are they simply a parasite on the system and just costing us money? Couldn't computer software take care of what they proposed to do?
I would say we have not examined that question and don't have a point of view to offer. I would say that our recommendations in the cost trends report do recommend that we have increased transparency around pharmacy benefit managers and pharmaceutical manufacturers so that we have better information and data to be able to answer that very question that you're asking, an important question.
Well, and in fact, right, Chapter 224 had originally passed did not include pharmacy as part of the cost trend hearings, and that's hopefully something that the House and Senate will consider. The Senate has passed its bill, but as the House considers its bill of including pharmacy as part of the cost trend hearings.
So the issue actually is worse than what you said, and we're now beginning to pull the leaves off the tree or the onion or whatever, and peeling back the onion. And what we're finding, researchers around the country, is that, remember, there is the actual manufacturer, and then it goes to the pharmacy benefit managers. Then it's priced, there's insurance companies, there's the pharmacy, and then there's the patient. So you got 5 actors, and it isn't like what these researchers have found is that a lot of the money has been sticking to these pharmacy benefit managers. So recently, 2 big insurance companies, and not only that, it was also sticking to the insurance companies. So the pharmacy, listen, I'm not defending the pharmacy manufacturers, but they're saying, you see the price you're paying. That's not the price we get. So what we're seeing around the country, and we need to do more of this, is, as Rod pointed out, first of all, transparency. Exactly what are the prices all over the place. But more importantly, when there are discounts that are those discounts ought to be pushed right to the patient who pays for it. And slowly we're beginning to see that. And more insurance companies are saying all of the reductions in price we will pass on. This is new. So you're absolutely onto something very important. And as the Secretary said, right now we've had limited authority in terms of really understanding what's going on. And if we get this added authority, we will be looking into that in much greater detail. Okay, I didn't mean
one other. Stuart?
Yes, please.
A question for David. Going back to avoidable emergency department use, prior HPC reports have shown that an area of growth in ER utilization is around behavioral health. As you look at this 20% decrease that you're projecting here, do you have an estimate of what that would, the piece of that could be behavioral health and could be more treated in appropriate community care?
Yes, that's a good point. The way that algorithm works to categorize emergency department visits, behavioral health is not in the categories that I showed. It's separate, and that doesn't mean that there aren't opportunities there as well, which we've talked about in ED boarding discussions and others. So that is another fruitful area, and it's not in those numbers.
Any other? If not, first of all, I want to thank both of you and the staff that put this all together. And I think it reinforces what I was saying before. There are many opportunities that we have in the Commonwealth to lower spending below the trend lines that do exist without affecting negatively the quality and access. So we're not dealing with a fixed number that cannot be adjusted. And I think the staff and David laid out a number of areas. There are other areas that he didn't even talk about. So that's what we're all about, to try to find these, to put pressure on the system to move in that direction. So thank you again.
Thank you.
Okay. All right, we're now going to turn to the part of the program where we're going to ask for specific comments by major components of our health delivery and financing system. Okay, so we're going to start off with John Hurst, who's the president of the Retail Association of Massachusetts. And following John will be Diane Anderson, who is the president and CEO of Lawrence General Hospital. So, and just to keep this moving along so we have time for questions, if you can keep your remarks to 5 minutes, that would be fantastic.
Thank you, Mr. Chairman, members of the commission. Good afternoon. Thank you for your service. My name is John Hurst. I'm president of the Retailers Association of Massachusetts. Statewide organization, been around 100 years. We have 4,000 members across the Commonwealth. I guess my point is, at this point, we don't believe it's time for champagne, pork popping, or backslapping, or in any ways, any sort of victory laps. The 3.1%, very important, and let's keep it there. If not, perhaps even drop it, because the reality is, not everyone is getting the 3.1%. Every year since the passage of Romney Care, we have surveyed our members, usually around this time, because small businesses generally see their new premiums April 1. And every year we have surveyed our members. The good news is this year it's slightly below our 12-year prior history of 12%. The bad news, it was 10.95. So 10.95 versus 3.1. And we keep this running chart since 2006. We compare RAM increases with GIC increases. Nothing against GIC, it's just public information. Big buying group, just as Raytheon or Walmart, anyone else, risk exemption would be large buying groups. Also, the inflation rate in the HPC benchmark. 12-year average for RAM has been 12.11. GIC, 12-year average, of course, they were fortunate enough to get 0 this year, 4.1. Inflation rate over the 13 years, 1.92 average. And the last half of those years, of course, the HPC benchmark has averaged 3.52%. Now, what is the differential? What explains the differential? The size of the pie is very, very important. How fast it grows is important. It's equally important from our standpoint, who pays what for the ingredients of that pie in proportion to the slice of the pie that they're taking back out for themselves. And therein lies the problem that we still have here in Massachusetts, that small businesses are not, in our judgment, are not getting a fair shake. Now, is it because we have the only merged marketplace in the entire country? 49 states still have separate small group and individual marketplaces, risk pools, made worse under the ACA, which was created to really deal with the 49 other states to still had the separate risk pools. And as we've lost our state rating factors, our fairness, the use of those rating factors to create fair rates for small businesses have evaporated. Is it unfair cross subsidies with others within the merged marketplace? Small businesses and their employees versus others, individuals, folks in connected care and the like. Is it unfair cross subsidies or healthcare industry profit margins for those in the merged marketplace versus big public risk pools or big private risk pools? In other words, the profit margins unfairly on the backs of small businesses. Is it the growth of state assessments and mandates which disproportionately hit those in the merged marketplace are oftentimes totally avoided by ERISA exempts, but unavoidable by small businesses? Is it the lack of appropriate priced limited tiered networks and wellness programs and financial rewards and true incentives within the merged marketplace for small businesses that incent good decision making and real rewards in return for that? Is it the lack of cafeteria plan type of offerings to small businesses, David, that, okay, maybe not everyone wants to buy, that works for your small shop, a plan with a wellness program or a limited or tiered network, so you have to go buy up and buy something that is appropriate for everybody because you can't give them a defined contribution, a real option, because the insurers and the brokers don't offer that to you. Is it the damage incurred upon small businesses by the lack of our cooperatives really flourishing because of the elimination of the ACA rating factor? Or is it all of these things? The point is the benchmark is very important, but quite frankly, it's been of little comfort or help to small businesses on Main Street. Perhaps it needs to be a negative number to bring them down from double digits down to single digits. Or perhaps we need to rethink the merged marketplace and try to find real, true, free market, equal rights for consumers, for small businesses that unfairly, arguably, are unfairly cross-subsidizing others and paying far more than their fair share. They compete every day with large businesses and large companies and large government for the very same employees. Yet their offerings and the price of their health insurance are not equal. Maybe this isn't the purview or the area of the HPC, David, but I think someone needs to deal with this, whether it's the DOI or Beacon Hill. It's something that needs to have a spotlight on it. And frankly, we need to find ways to make small businesses down closer to that benchmark. Thank you for your work, and we look forward to working with you and everyone else on this important issue.
And that was extremely helpful. Thank you. Are there any questions or comments of the speakers? If not, we will look into that in more detail. So thank you very much. Diane?
Thank you. Good afternoon. Vice Chair Roy, Chairman Altman, Secretary Sutters, Executive Director Self. I'd also like to recognize Representative Dykema, who is my neighbor around the corner in Holliston. I'd like to thank you all for inviting me today. As you all know, Lawrence General Hospital is a growing regional medical center with excellent medical, surgical, and trauma capabilities. New surgical building, an emergency department that sees over 70,000 patients a year from all over the Merrimack Valley and beyond. We're a high value, low cost, high quality organization, and we've succeeded actually in attracting more patients, thereby keeping more care local instead of sending our patients into higher priced academic medical centers in Boston. But one of our most significant challenges is our payer mix, because it includes very low relative rates of payment from our commercial payers and a very high exposure to Medicaid as a disproportionate share hospital, for which we're now at risk. We also have a proven strategy for success, evidenced by our growth in key services and programs, and basically last year saw over a 4% increase in our volume in 2017. I'm very grateful to have the opportunity to testify today, and I really want to thank the HPC for inviting me, because the cost growth benchmark impacts us significantly, and many other hospitals like us. While the overarching philosophy of the cost growth benchmark is a very good policy initiative at the Commonwealth, it has not played out particularly well for providers like us. The unintended consequence has been that payers have used the benchmark as a leading rationale for very modest increases in negotiations with underpaid independent community hospitals, regardless of whether we negotiate through a larger enterprise or independently. My colleagues and I are focused on unwarranted price variation and believe strongly that without legislative intervention, we will never catch up to any rate that approximates an average relative price. And it's not only the hospitals like LGH that have looked ahead and estimated that we will never catch up. The HPC, in their excellent work in 2015, performed a calculation which showed that the unwarranted price variation is unlikely to diminish over time absent direct public policy action to address this issue. The HPC modeled the time it would take for the lowest paid hospitals to reach the price level of the 75th percentile with an assumption of an annual 3.6% price increase, and it would take 16 to 19 years to catch up to the 75th percentile. While establishing an acceptable cost trend is a very laudable policy, it has had unintended negative consequences. In fact, from 2015 to 16, LGH went from the 5th lowest paid hospital of 63 hospitals to the 3rd lowest. I would encourage the HPC to send a policy signal to payers that the benchmark is an aggregate growth benchmark, never intended to lock providers in the basement of rates. The communities we serve need access to the same services and quality of care and as many other organizations around us, but to provide that care, we really need adequate reimbursement. The HPC board has indicated their interest in evaluating certain factors relative to the benchmark, including overall health system performance, changes in the federal landscape, and enrollment impacts. There is no other better bellwether for the impact of these market dynamics than Lawrence General. We're significantly exposed to state and federal funding, and do believe that the Commonwealth has done all it can to negotiate the best deal possible with the current Medicaid waiver. I would encourage the HPC board to include in their recommendations concerning the cost growth benchmark a policy directive that signals that this benchmark is not intended to be used to hold back appropriate rates to providers who have been perpetually underpaid. Thank you for your thoughtful consideration and all of your excellent work.
Thank you very much. Are there any questions? I just want to make it clear that under no circumstances have we ever said to the payers that they have to pay that rate to every provider. This is a complicated issue, as you know well. We've had hearings at the state level, and you're so right. I mean, it's a complicated problem, and as you know, we've been trying to promote as much as we could the movement of more care to hospitals like yours. So we appreciate your testimony very much, and we will make sure that in future reports, we make it clear that this is not the only number that should be used for every provider.
Thank you very much.
Thank you. Our next presenter is Susan Fendel, who represents the Mental Health Legal Advisors.
I'm Susan Fendel. I'm senior attorney with the Mental Health Legal Advisors Committee. We're an agency under the Supreme Judicial Court, and we provide representation and advice to people throughout the Commonwealth who have issues concerning mental health legal matters. We also give advice to the legislature and commissions, usually whether they want it or not. In considering the potential drivers of healthcare costs and practices that reduce healthcare expenditures, we have very specific recommendations as to what to look at and what to consider. One thing is that financial incentives to reduce costs often have unintended results and should not be pursued without careful scrutiny and transparency. Innovative approaches to healthcare that are not typically covered by insurance are fundamental to reducing costs, and that healthcare delivery systems like integrated care should not be assumed to be beneficial to all persons or to result in decreased healthcare expenditures. financial incentives often place providers in the position of insurers, which obviously can mean that care is cut and outcomes may suffer. Allegedly, outcome measures are supposed to control that financial incentive, but things like hospital admissions are a crude barometer of clinical outcomes, in that people, for example, with depression may never turn up at an emergency room or in an inpatient hospital situation, but their quality of life, their ability to function in the workplace, etc., may be very low. We should be looking at patient-reported outcome measurements to really look at whether different financial incentives are working. We also should think twice about cost shifting to patients. Tiering, I believe somebody asked about why don't patients choose the lowest cost hospital. Well, most people, when they are looking at their own medical care, are not in the situation where they're going to be shopping for healthcare like they shop for appliances. They are concerned and probably not feeling great about their health. They are going to take the recommendations of their doctors. They are going to go by reputation. And they are not going to be doing extensive research on quality measures versus cost versus, they are going to go by what their doctor tells them to do. Increasing copays and deductibles. We know that, for example, with medications, increasing copays very often leads to medication non-compliance because of the cost of the medication. And so in the long term, you have people cutting their pills in half or not taking it at all. And that results in larger costs down the road. So I would suggest that there needs to be a real serious look at alternative payment modalities and cost shifting to look at actual outcomes, and which should include patient-reported outcomes, functional assessments, and social costs, as well as process measurements. A large point that we would like to make is that we cannot expect to lower healthcare costs by doing the same old, same old. We need to be looking at innovative services. One example is peer respite. The DMH commissioner, Joan McCullough, has spoken favorably of peer respite's efficacy, but only one peer respite, which is a place that people with who are in psychiatric crisis can go, and it is run by people who also have lived experience of psychiatric crisis.
Susan, if you could just.
I'll do it. But these peer respite reduces inpatient and emergency service use. Quickly, besides Housing First, service animals, which there's great, and peer supports, which there is a considerable amount of evidence. I would ask the HPC, when they are considering performance improvement plans, to consider whether or not these innovative services are being used and whether they should be part of the performance improvement plans. And then finally, while we promote evidence-based care, promote evidence-based services, we do not provide the same scrutiny to healthcare delivery systems. According to research, and I will be providing a written
That's very helpful.
testimony, there is very mixed results in terms of both costs and in terms of outcomes from ACOs and integrated care. People with behavioral health issues in particular, because of bias within the physical health care system, attributing things to a person's psychiatric condition, do not get adequate physical health care, do not benefit as much from ACOs and integrated care as one might assume. And also looking at social determinants of health. Secretary Sutter spoke about looking at other countries, and other countries spend much more on social determinants of health and have better results. So I appreciate you letting me ramble on, and thank you very much.
Well, you're talking about an increasingly complex problem, so, we should, I'd love to be able to give you more time, but and it'd be very helpful if you could put this in writing and send it to our staff, so thank you very much. Our next presenter is Sarah Gordon-Mita, who represents the Massachusetts Association of Health Plans. Welcome, Sarah.
Thank you. Good afternoon. So my name is Sarah Kiramita. I'm the Vice President of Legal Affairs and Public Policy for the Massachusetts Association of Health Plans. We represent 16 member health plans that provide coverage to 2.6 Massachusetts residents, including Medicaid, commercial, Medicare, and through the connector. We thank you for the opportunity to comment today on the potential changes to the 2019 healthcare cost growth benchmark. Opening up, we support keeping the benchmark at 3.1%, but we would like to note some of the, we agree with some of the findings that were presented today and note some of the policy considerations from the Assembly and representatives from the legislature to consider going forward. Massachusetts healthcare costs, as we know, are among the most expensive in the United States and continuing to grow. We know that access to healthcare without addressing underlying healthcare costs will continue to put enormous pressure on employers, individuals, families, as well as the state budget. As premiums reflect the cost of care, we believe holding ourselves accountable to a strong cost growth benchmark and addressing the cost drivers are essential to making healthcare more affordable. While we have led the nation in healthcare access, the costs remain the highest in the nation. We recognize that we have made tremendous strides in slowing the annual growth, and that is due mostly to our cost growth benchmark. And we're fortunate to have the wealth of information through the various state agencies, including the commission, to provide us more information around these factors. And those are, as we heard today, the persistent increases in prices charged by providers, coupled with care largely being delivered in high-cost settings and by high-cost providers, and the excessive prices being charged by the pharmaceutical industry. These are all contributing to the rising cost of care in the Massachusetts market. We'll continue to threaten the benchmark regardless of where we set it. And while we support keeping it at 3.1, we definitely support keeping the focus on addressing these factors and recognize that more work needs to be done. I'd like to talk about a couple of those today. We believe that the state must undertake efforts to hold pharmaceutical manufacturers accountable for the prices that they charge. As we heard today, prescription drug prices represents the highest growth driver in the last several years, along with increases in outpatient spending. As the Commission measures the system's performance against the benchmark, it will be important for pharmaceutical manufacturers to justify the price increases, and we fully support increased transparency around prescription drug costs. So the legislature and the House is also considering healthcare cost legislation. We support increased transparency on pharmaceutical costs. And while health plans and providers are subject to the benchmark and accountability on the annual healthcare cost trends, we also agree and support proposals to add pharmaceutical manufacturers to the annual cost growth hearings to explain the reasons behind these prices charged for new and existing drugs. We also support addressing provider price increases in healthcare in high-cost settings. Over the past 8 years, more than 24 state reports have examined the healthcare costs, and report after report have found that provider prices remain the most significant factor driving healthcare costs. And they've also found that wide variation in prices, and those are not correlated to quality, acuity, or some of the other factors that the we have taken a look at. As the Commission's January 2018 presentation noted, additionally, the HPC has received 90 material change notices and 42 of these transactions involving position group acquisitions or contracting affiliation, increase in market concentration for physician services, and we know that consolidation also contributes to increase in price. We appreciate the Commission's continued efforts to monitor whether the transactions that have been approved to date have actually resulted in lower costs and better care for consumers and employers, and we support the Commission's continued investigations going forward. As the Commission monitors performance against the benchmark in this area and sets priorities for addressing costs, it's important to pay special attention to these transactions going forward, including how the actual results align with the anticipated benefits providers articulated in their material change notice, whether or not they have leveraged higher prices as a result of these transactions, and what impact the concentration of institutions is having on the state's ability to meet the cost growth benchmark. In addition to rate increases, including those that follow an approved provider consolidation, we ask that the Commission continue to consider all of the relevant factors that contribute to our ability to meet the benchmark, including the fact that more care is being delivered in high-cost settings by high-cost providers, increasing member disease severity, and the general availability of new technologies. We also support a continuing analysis of provider cost structures to help us better understand how a provider's margin is impacted by its cost structure. So we appreciate the ability to, the opportunity to provide these comments, and as the Commission considers the benchmark, and I'll take any questions.
Sarah, thank you so much, and we appreciate all the assistance we've gotten over, and we'll continue to work with your organization. So thank you very much. All right, our next speaker is Dr. Paul Hattis. It's always a pleasure to have the former commissioner join us. Dr. Hattis, we look forward to your comments.
Thank you, Chairman Altman and Vice Chair Roy, members of the House, and other commissioners. The other hat I'm wearing today is I'm still a public health professor at Tufts Medical School. I hear 11 of our students are taking a course with the HPC, and they're here to observe because they're all going to be, if they want, future health policy commissioners.
Are you going to give them an exam on what went on?
I'll make sure they pass. Okay. That gave them some relief, I'm sure. Okay. All right, I am though here not representing either of, not representing Tufts Medical School. I am a member of the healthcare team of the Greater Boston Interfaith Organization, a community organization representing about 50 primarily religious congregations who come together to advocate for social justice, including in the healthcare realm. And we thank you for the opportunity to allow us to testify in this second annual hearing focused on whether the HPC should recommend raising what we call the GBIO AIM growth benchmark level of 3.1% to a higher level, which you can do as much as 3.6% for 2019. Like last year, we say to you again, don't do it. As we noted, when the 2012 cost containment law in our state was negotiated, GBIO, along with the Associated Industries of Massachusetts, strongly advocated the legislature create an overall healthcare spending benchmark, which needed to be set for some number of years at a level less than the expected growth of the economy. The legislature ultimately responded to our two organizations' call by setting the level to 0.5% less than predicted growth of the economy for years 6 to 10 following the passage of the law. We now find ourselves in that period. Despite some success since 2012 in moderating annual spending increases as compared to the prior decade, GBIO continues to be struck by the staggering amount of waste in healthcare spending in our country, and of course, even in our own state. While there's many causes, and I appreciate the two Davids talking about things tied to unnecessary utilization, I completely agree those should be taken on. In fact, I wrote a Commonwealth Magazine article last April saying that the HPC ought to hire more staff to get yourself more into that issue. But I'm not really here to focus on that. I'm a little bit closer to where Diane Anderson was coming on, reminding all of you that there was a recent JAMA article by Papa Nicholas et al. That said that, reminding us that Uwe Reinhardt, the late Uwe Reinhardt's observation that it's the price is stupid, meaning it's unjustifiably high commercial prices paid to providers or vendors that contribute significantly to wasteful healthcare spending in the U.S. In fact, that along with administrative spending in healthcare is what distinguishes us from the rest of the OECD nations. And we know from data that HPC cite every year in reports, the problem is exaggerated here with our healthcare providers, where over 80% of care is delivered by providers paid in the highest two quartiles. And of course, added to that, as you know, that some of our providers with significant market share of brand name power, that highest quartile are paid supernormal prices because of their unchecked bargaining power. Let me say with the members of our House here, I'm sorry that the Senate members aren't here along with you, but the failure of our state legislature to deal with that source of waste is really indefensible from GBIO's perspective. Though the Senate this session, to its credit, has passed a provision to try to begin to deal with provider price variation, including putting a check on some of the overpayment as necessary to live within the stated norms of that law's provision. But let's see what the House does this spring. You couldn't honor Representative Colcott's memory more, in my perspective, in doing something on that issue in your legislation this year. But in the face of that gaping price variation move, commissioners keeping the benchmark as low as possible under the law, while admittedly a weak band-aid for legislative inaction to date, at the margin, we think has some value for adding a bit more discipline for commercial price negotiations, even affecting the most powerful providers. Said slightly differently, if you decide to recommend raising that total spending growth benchmark, and if it does influence ultimately real healthcare spending in 2019, it's because that higher conceptual level primarily drives commercial prices that providers are paid, not utilization. So if you raise it to benchmark at 3.6%, people won't get more care. There's only a conceptual kitty for market participants to fight over price increases, which would then be about $300 million larger than if you keep it at 3.1%. Why give away our money like that? And you know, Diana Anderson's hospital is not going to be the one standing in line first to grab any of those needed dollars, perhaps. But she and some of her other colleagues. So let me turn to a second issue, which I'm just going to briefly summarize. I think
we're going to need to move it quickly.
Okay. All right. The second issue is, you always say that you only have bully pulpit power, but remember this year, because of your fine work, one completed on acquisitions and one in process, that as DPH writes conditions, sometimes it's specifically utilizing the benchmark you set to affect either a pricing or potentially a spending issue as it sets a condition tied to those acquisitions. So when you set a lower benchmark, you actually could affect lower spending. Finally, and perhaps most compelling in GBIO from the social justice perspective, it was the very thoughtful recent Health Affairs article by David Cutler that I want to cite to you at his conclusion. He says that every dollar that is spent on medical care is one less dollar available for addressing the problems of an unequal society, and one more dollar that is difficult for much of the population to pay. One of the goals for health policy must be to reduce social and economic disparities, not increase them, end quote. Professor Cutler is reminding us that sadly in the U.S., healthcare financing is a regressive enterprise. It doesn't have to be, but the way we currently do it means that the more we spend on healthcare, the more we tend to create greater inequities for those who are economically in the bottom half of American society, or increasingly even, don't have to be in the bottom half, even maybe the 2/3 of American society. So keeping the benchmark growth rate as low as possible under the law is at least one important way for the HPC to say that it is on the side of those wanting to reduce disparities between the haves and have-nots. Thank you for the opportunity to testify via the GBI.
As usual, very thoughtful. Are there any questions of Dr. Harris? If not, we're going to turn to our next presenter, Mike Sikowski, with Massachusetts Health and Hospital Association. Thank you.
Mr. Chairman, members of the committee, and the commission. Thank you for the opportunity to offer brief comments today. For the record, my name is Mike Strozinski. A lot of consonants at the end of it,
Apologize for that.
It's an everyday occurrence for me, no worries. Thank you for the invitation. I'm standing in for Steve Walsh today, MHA's president and CEO. He very much wanted to be part of this conversation today. However, he was committed to a speaking engagement outside of the city, and unfortunately unfortunately cannot frame the schedule, but I know you'd be happy to follow up with any of you after the fact today. I'm here to convey MHA's support for setting the benchmark at 3.1 for 2019. We believe the partnership between HPC, the provider community, payers, and patients has been an important one that's brought about meaningful change in the Commonwealth. There's still clearly much more we can do. We've heard a lot of that earlier today in the comments, but we think it's important to keep the aggressive benchmark in place and ensure that we're all working together collaboratively to move the state in that direction. I've offered detailed written commentary about our position. While it highlights our support for the 3.1 benchmark, it also notes a number of the challenges that should be taken into consideration. A lot of them elements that often fall beyond providers' control. You heard of some of them today, and not necessarily fully out of providers' control, but also drivers of cost, behavioral health, social determinants of health, an aging population, rising pharmaceutical costs. We're very appreciative of the efforts that this commission has put in place to bring about greater transparency and put a little additional pressure on the pharmaceutical industry. We believe more needs to be done on that front, or else the task of achieving our benchmark is near impossible here in the state, and we're happy to partner with you on any of those efforts. I'd also like to note our support for one of our member CEO's comments earlier here today, Diane, that the 3.1 is, well, the benchmark has been used against a number of hospitals as a hard cap, and any further specification or verbiage from the commission to illustrate that that is not, in fact, a hard cap on providers would be helpful, I think, particularly to those entities that do not have the negotiating leverage that some others may have. So her remarks are very well supported by the association. There's one other consideration I'd like to raise that hasn't come up today, and I hope is on everybody's radar screen. There's a proposed ballot question that's slotted for the November 6th statewide ballot this year. It's proposed by one group seeking to impose mandated at all time nurse staffing ratios in all units of all hospitals at all times. Besides the very real negative consequences to care and access that we think this ballot question poses, initial estimates show the cost annually to be well in excess of $800 million a year to the state. That is an impact that's going to be felt not just by hospitals, not just by the downstream providers such as nursing homes, community health centers, home health agencies, who will be forced to pay exorbitant wage inflation or else lose their nurses to hospitals as a result of this mandate. But it's also going to be felt very much by consumers in the state through increased premiums, potentially taxes to support the Medicaid program. This model of care, which we would say is an antiquated approach to care, setting forth an assembly line notion of care within a hospital, would, in our perspective, freeze the important advances we've made to date in this Commonwealth. And we hope the Commission takes a very close look at this proposal and is willing to dive into some of the data with us to understand the consequences that it poses. We'll be doing what we can to defeat this proposal, but if it does go into effect, if we are not successful in defeating it at the ballot, it will be in effect as of January 1st, 2019. And I can tell you the consequences are going to be real problematic from both an access and cost perspective. So I'll conclude my remarks with that piece. We look forward to following up with all the members of the Commission and the committee on that particular issue in the days ahead.
So Mike, thank you very much, and we will be working with your organization, and obviously you've laid out the issues that are really on our agenda as well. So are there any questions or comments?
Mike, I want to just ask you to say a few more words about the cap issue. So Diane presented a very compelling case for distributional effects of applying the limit across the board. What principle should we use in making sure there's equity in what we're demanding of hospitals in the state in terms of their efficiency? How should we think of that?
You know, it's been a driving priority around our board table at MHA to look at this issue. We've made several recommendations over the years. During the Senate healthcare debate, we supported the establishment of a floor for providers. You know, I think that's one way to look at it. I'd also ask, you know, as we come at this as a hospital community, we're hoping that we can bring some answers to the table. It's a difficult equation to get at. And also, let's we put in a little bit of context. I don't want to overbeat my message, but if we look at this ballot question, it's $800 to $1 billion a year. The price variation issue, so-called, is, I think, on an annual basis, a fraction of that to cure. So if we're ever hoping to solve that problem, we need to make sure some of these larger challenges are up. It may not be a direct answer to your question, but I can assure you that it's one that's part of our daily conversations within the association.
Okay, any other comments or questions? Again, Mike, thank you so much.
Thank you.
All right, our next presenter is John Irwin, who represents the Conference of Boston Teaching Hospitals. John? Good to have you join us.
Thank you. First, I apologize. I'm getting over a case of laryngitis, so I may at some point just be speaking and nothing comes out. So my name is John Irwin. I'm Executive Director of the Conference of Boston Teaching Hospitals, which is a group of 12 Boston area teaching hospitals. And thank you for the opportunity to testify today. At the outset, we also support retaining the 3.1% cost growth benchmark. As Dr. Auerbach's presentation showed, in 2 of the past 3 years, we've exceeded the benchmark. In the current year, for which final numbers aren't ready, we are below that. But when you look at different components of total healthcare expenditures, and within that, major components within, say, the commercial category, there remains wide variation in the levels of growth. We do not support disaggregation of the various elements of the benchmark, but it's important to look at each one of those and see how each one impacts the overall cost benchmark, and how in many cases a lot of those components are beyond the direct control of providers. For instance, taxes and assessments imposed by the Affordable Care Act, growth in mass health enrollment, the cost of new drugs or innovative equipment are all significant cost drivers, but in many cases beyond the direct control of hospitals. The cost pressures facing hospitals are many, and one of the largest components of our cost is labor. 60% of all hospital costs are directly related to labor. So, and in addition to typical inflationary pressures on labor costs, a pending nurse pallet staffing initiative, which mandates specific nurse-to-patient ratios, would have significant impact on hospital costs. As the MHA points out, it's in excess of $800 million a year. There's no scientific evidence proving that approach improves the quality of care, but I think you could easily say that type of spending would crowd out other possibilities of spending in terms of potential investments in initiatives that would increase access or improve quality at our hospitals. Another element that we hope the HPC will look at when setting the cost benchmark is the uncertainty at the federal level. I had similar testimony a year ago when there looked like repeal and replace might happen. While a direct repeal and replace may not happen this year, there are many efforts underway through regulatory bodies to undermine the Affordable Care Act. That, combined with proposed changes to the 340B drug pricing program and other changes to Medicaid, all could have a severe, significant impact both nationally and locally here on healthcare costs. So in closing, we do support the maintenance of the 3.1% benchmark, but we caution that the HPC should be aware of these elements kind of beyond our control that really could have a dire impact on the meeting the benchmark in 2019. But regardless of where the benchmark is set, we stand ready to continue to work with the HPC and the Healthcare Committee on containing costs in the state and retaining and maintaining growth below the benchmark. Thank you.
So thank you very much, John, and get better. And don't add to our healthcare costs. All right, the final speaker that I have on my list, and if there's any others, please let our people know, is Christopher Carlucci, who represents the National Foundation of Independent Businesses. Welcome.
Thank you, Mr. Chairman and members of the Commission. My name is Christopher Carlozzi. I'm the State Director of the National Federation of Independent Business, representing nearly 6,000 small businesses across the Commonwealth. Our members are involved in all types of industry, including manufacturing, retail, wholesale service, and agriculture. The average NFIB member has 5 employees, and in short, NFIB represents small Main Street business owners from across the state. Small business owners in Massachusetts have ranked the cost of health insurance at or near the top of their list of concerns for probably over a decade now, maybe longer. The price tag of healthcare in the Commonwealth is a significant cost of doing business and a significant consideration when creating a new job. Unfortunately, health insurance expenses continue to increase annually, and efforts to get the cost increases under control always seem to fall short of expectations. Last month, we conducted a very unscientific poll asking NFIB members whether they will see their health insurance premiums increase, decrease, or stay the same in 2018. The vast majority of respondents replied they would experience an increase, and we estimated at an average of 12% premium increases. But these increases are no great surprise, since most of our members have experienced double-digit premium increases year after year. While the increases may be routine, it makes them no less painful for struggling small businesses. Many of our small business members were in disbelief when they witnessed recent news reports announcing workers covered by the GIC health insurance will see 0% premium increases, and in some cases even reductions. The notion of 0% premium increases and rate reductions is simply unheard of for small business owners in the Commonwealth. What factors results in small businesses paying perpetual cost increases annually while others see reductions? I doubt that workers at a small business are any less healthy than state or municipal workers, so why are NFIB members seeing on average premium increases of 12%? I think John Hurst and the retailers went through a pretty good list of other questions. Like any household, municipality, or even the state, health insurance costs are not contained within a vacuum for Massachusetts small businesses, facing operating and labor cost increases across the board. Our state is prohibitively costly to run a small business, with highest in the nation energy costs, mandated paid sick leave regulations, and high unemployment insurance rates. Many small business owners will also soon experience the price tag associated with the new Mass Health Assessment when they attempt to make their UI payments this April. I've already received several calls from small business owners completely overwhelmed by these mounting expenses. This doesn't even begin to cover threats to their livelihood on the horizon, like a potential $15 minimum wage or mandated paid family and medical leave. Each of these mandated benefits, while not necessarily related to healthcare, whether passed by ballot of the legislature, make healthcare affordability even more difficult. What is especially frustrating is that groups pushing for these increased labor costs are also in turn indirectly driving up the cost of health insurance. As we just heard, the Massachusetts healthcare industry will also have to absorb these higher wages and increased time off benefits, no doubt passing the cost along to consumers like small businesses and their workers. But solutions to the health insurance cost crisis for small business and their workers who shoulder the premium costs are often difficult to implement. The answers include more transparency for consumers, giving them more choices and providing more competition, not less. NFIB is strongly in favor of more free market solutions to lower costs through competition and choice. Government, and this falls mainly with legislative action, must seek ways to instill competition into healthcare by reducing mandates. Many medical procedures are not always emergencies, and consumers can be given information that allow them to choose the best care and the most cost-efficient care. Among Massachusetts healthcare reform efforts, costs have always come second to quality of care and access to insurance, but it's time to recognize that cost is the biggest barrier to care. Small businesses can no longer endure annual double-digit premium increases. Much like the Commonwealth is experiencing with their budget process, healthcare expenses are also devouring small business budgets and crowding out revenue to grow, hire, and expand. For the sake of the economic well-being of Main Street businesses across Massachusetts and their workers, we must work to reduce health insurance costs for thousands of struggling small businesses. Thank you.
Thank you, Chris. Any questions or comments? I think both of you have laid out this issue, which is an issue we need to look into exactly. Those, there's no question that you are being subjected to increases that far exceed the average in the state or other areas. So we really appreciate your comments.
Thank you.
Are there any other presenters today? If not, this brings to close the formal presenting. I just want to make some comment. Again, as I said in the beginning, every one of you, the those of you who represent major providers, those of you who represent our payers, those of you who represent consumers have suggested that we maintain the 3.1%. Again, I want to thank you. I mean, this is a tough number. As Ron has pointed out, you know, it is below the past numbers and it's below much of the country. And the fact that you're asking us to continue that number says a lot about you and your commitment to making sure that we can keep our spending in line with what we can afford. So thank you very much.
Mr. Chairman?
Yes.
I would just like to, I do think, I think the comment that was made by a couple of folks we need to be very present about of how we communicate that the benchmark is, it's not a hard and fast a cap across all providers and the like, and I think how we communicate that is, that's the overall benchmark, but that we understand, because we had this conversation before about behavioral health always having been sort of under reimbursed and the like, but that's important. And just for the record, I would go lower than 3.1. I know that's not an option, but the fact that you continue, even though sometimes it's an aspiration, you have to keep sort of putting numbers out in order to really keep driving that. But I say that having just made the comment that I want to ensure that this is not a hard cap.
Other comments? Okay, now
Mr. Chairman, I would just highlight, we are accepting written testimony until Friday, and we will be putting all of the written testimony up on our website. And for the members of the Joint Committee, we'll be circulating the written testimony to you as well. And we'll be back at a board meeting on the end of April for consideration of whether to modify the benchmark. But we will make all of that testimony available publicly.
Again, the next scheduled board meeting is April 25th, and it will take place here at noontime. Is that okay? All right. With all that said, do I see a motion to adjourn? All right, all in favor? Okay. Well, we're adjourned. Thank you all very much.
But